MRD is definitely one of the most informative, if not the most informative marker for response, much better than the historical assessment of response like complete remission. And this has been shown in many, many trials. And the prognostic power of MRD is, of course, relevant in terms of outcome. Patients with sustained MRD negativity, which means more than one MRD test negative over time, usually within the first 12 months, but it can be also longer than that. These patients have an excellent outcome. And so some of them have been in remission for many, many years. Patients that lose MRD negativity, so they are negative and then turn positive, most of these patients unfortunately progress, and we can predict that pretty early on time. And then there is a group of patients with MRD positivity that some of them can still achieve a long remission, and we still don't know why. But overall, the utility of MRD negativity, I think, is around two different levels. So one is the prognostic and trial interpretation level. So you work around the data from clinical trial to better understand if your treatment or the alternative treatment in case of a randomized clinical trial has a better effect or impact on the disease in terms of eradication and depth of response. The second level is more like what we can do with this data. So once we know that MRD is negative and the response is deep, how this change? Because it's not a baseline prognostic marker. We barely cannot predict who's going to get MRD negativity, who's not. So because multiple myeloma has currently an approach that is mostly based on continuous treatment, so keeping the patients on therapy for as long as possible in some centers or for a certain period of time in others, there are different trials and experiences. The idea is that similarly to other tumors like chronic myeloid leukemia, where MRD was one of the first place where it was introduced, and the suspension of therapy based on MRD was developed. So the idea is we can use the same experience, and for example, patients with a sustained MRD negativity can, interrupt their maintenance at a certain point. And so the idea or sustained MRD negativity or MRD negativity as a tool to adjust our treatment over time and to adjust the risk for the patient over time and to shape our strategy on the patient response are actually important concepts that already people are doing. There are already at least 2 trials where this has been done. And I think the most important is the master trial from Luciano Costa and his team, where they show that if you discontinue lenalidomide maintenance, when you are sustaining MRD negativity, you still have a lot of patients, most of the patients are still in remission. All along with the Manhattan trial, even if there was not an MRD adjustment treatment, it shows that a lot of patients that didn't receive transplant are still MRD negative after several years. And that's an experience also from other studies. So this means that we are entering an era where the idea of we treat all myeloma in the same way is start progressively to have less sense. And we need to start to think about adjusting our treatment based on the real risk, which is a combination of comorbidities, clinical features, and genomical features, properly analyzed and investigated, and the dynamic features like MRD to understand if a patient needs transplant, if the patient needs a maintenance, for how long, or a consolidation, which drugs. So these are important questions that I think in the next year we'll be able to address thanks to this new technology and also thanks to the fact that the myeloma community realize how much important are this feature and this analysis for the interpretation of clinical trials.